All right, everybody, welcome. My name is Amelia Curtis, and I'm the Education and Training Manager at San Diego Humane Society. I oversee all of our speaking engagements that we host for the public, and we are so honored to have Fear Free with us this evening and our special guest speakers. So I want to go ahead and hand it over to Stephanie Bachman from Fear Free, who is going to let you know a little bit about the Fear Free organization and what our speakers will be discussing tonight. And then I will go over some housekeeping before we get started. Welcome so much, and thank you guys for being here.
Thank you so much for that introduction, Amelia. My name is Steph Bachman, and I'm here with my cutest but worst coworker, Izzy. But I'm the customer experience manager for Fear Free. We're really excited to work with San Diego Humane to put on this webinar in the first place. So we're really excited to be here. Fear Free itself is an online education provider that caters to veterinary professionals, pet professionals, animal welfare communities, and pet owners. Our courses and content are developed and written by the most respected veterinary and pet experts in the world. We pride ourselves on being scientifically accurate in focusing our educational content on emotional well-being, enrichment, and the reduction of fear, anxiety, and stress in pets, and improving the experience of every human and pet involved. I'm confident that today's webinar with behaviorist Dr. Megan Herron and technician with a specialty in behavior, Jessica Benoit, will show how fear-free concepts and techniques can improve the way any veterinary professional practices. If you have any questions about our online memberships or CE offerings, please email us at wags@fearfreepets.com. I will include that in the chat here in a second. So thank you so much for attending tonight. And with that, I will hand it back to you, Amelia.
All right, thank you. We also have with us this evening our Vice President of Shelter Medicine, Dr. Zara Hedge, and she would like to just do a little welcome as well.
Hi, everyone. Welcome. Thank you so much for attending tonight. This is really exciting for all of us. We're so happy to have both of you here to speak to us tonight about Fear Free. A special thanks to our SDCVMA who sent out this opportunity to all the members and to our VCA clinics and partner hospitals as well. So I hope everyone enjoys tonight. Thank you again for joining us. We're really excited to be doing this.
All right, perfect. So just some housekeeping. I'm going to put in the chat a Google Doc link, and that will have your sign-in sheet. So everyone who is in attendance tonight will need to sign into that Google Doc, and that will make sure you get your certificate for attending this evening. We are also recording, so everyone who has registered will receive the recording, but only those who have attended live will get the certificate and the credits for attending. We are going to be doing questions at the end of each presentation. So you are going to be muted, and also your screen will not show since we are in webinar mode. So you can hold those questions for the end of each presentation. If you have something you think of right away and want to pop it into the Q&A or the chat, we can start to gather those, and we will be asking them towards the end. I'll be managing those. We'll try to get through as many questions as we can for each presentation. This presentation this evening is approved for 2 race hours of CE. So that is what you'll be receiving the certificate for. I will also be sending a follow-up email with that recording and any notes that the presenters will be providing. So with that, I'd like to introduce Megan Herron, who will be speaking on Better Living Through Chemistry, Shelter Dogs.
Thank you. Let me share here. All right, here we go. So those of you who don't know me, I'm a veterinary behaviorist, and I am the Senior Director of Behavioral Medicine Research, Education, and Outreach at GG's, which is a fairly new organization near Columbus, Ohio, where we do house shelter dogs, but we also are an organization dedicated to improving the lives of shelter dogs, working with several of our rural Southern Ohio shelters, as well as adoption partners throughout the state of Ohio. Prior to that, I spent a decade at The Ohio State University in clinical practice and veterinary behavior. So I shifted gears about a year and a half ago, and I just want to tell you how much I have learned in that brief amount of time. Yes, there was a pandemic as well, but aside from that, just so much I've learned about dogs and behavior and how stress affects them in these environments, even if you have a palace of a shelter like we are fortunate enough to have. So I wanted to share just some information on how we utilize psychopharmacology, aka better living through chemistry for shelter dogs, which really aligns well with all of our fear-free concept. So I was very happy to become a part of an organization that embraced fear-free really through thick and thin. There we go. Okay, sorry about that. All right, so what we want to see dogs that are adaptable. And by that, we mean dogs that have good coping skills, because dogs who are coping well are going to rely less on maladaptive, repetitive, and other undesirable behaviors. And dogs whose physical, mental, and social stimulation needs are met will be less likely to fill those needs through other undesirable behaviors. And so really our goal is to help these dogs cope as best as they can. So they're showing the best behaviors they can, and therefore also having the best welfare and adaptability as possible. So what happens when dogs can't cope, or they aren't coping well in a shelter environment? Those of you working right now in a shelter have probably seen both of these things time and time again. Either their behaviors are exaggerated or they're inhibited. So you might see a dog that was super rowdy, really active, hyper, difficulty settling, mouthy, jumpy, really kind of difficult to manage and handle in a shelter environment. They get adopted or they go into foster and they completely calm down, totally different dog. So you wouldn't have been able to predict that based on their behavior in a shelter. And then you'll often see the opposite, where you have dogs that are very shut down. They seem very calm, seem very docile in a shelter environment, yet we get them into a home and we have people calling us saying, wow, what's going on? This dog's bouncing off the walls, can't settle, is tearing up my furniture, is pulling me down on walks. You know, once they got through that sort of honeymoon period, their true colors come out because their stress was inhibiting their behavior so intensely in that shelter. And which route a dog's behavior is going to go in response to stress of a shelter is really going to depend on each individual dog's coping skills. We just can't say or predict how a dog's going to cope in a certain situation. But really the key is to reduce that stress in order to change or really give us the true colors of a dog's behavior. Adrenaline mediated states are not conducive to learning. They don't learn well because they're in fight or flight. And that's really about survival, not about sit or not jumping up, not mouthing, you name it. They're just in a different state of mind. So before we start talking about psychopharmacology, and our next wonderful speaker is really going to delve much more deeply into enrichment and other aspects of stress reduction. But at GGs, we really try to have a formula to provide for physical, mental, and social stimulation needs. Sort of the triangle of activity I've created, where a big part of the triangle is full of physical exercise, where we have the dog's muscles moving in some way, shape, or form, if possible, for 20 minutes. And again, when you have a full shelter, sometimes that isn't feasible, but that's kind of always the goal we strive for. And then we sort of narrow it down to a calmer state through mental stimulation. So whether this is teaching them something new or having them do sits and downs, what we call puppy push-ups, just using that brain a little bit with positive reinforcement training for a handful of minutes. Often a shelter dog's attention span is not very long, so we try to keep it to a minimum. And then we work on kind of calming them down with one-on-one social time for a few minutes, whether that's petting for a dog that enjoys long strokes, whether it's just sitting next to them so they have some company in a calm, quiet environment. And then we sort of pin the point of the triangle by allowing them to engage in some sort of self-driven enrichment, whether that's a treat bomb when returned to the kennel or some sort of food puzzle toy when we return them to kennel. So they have something to sort of self-soothe and settle now that their other physical, mental, and social needs have been met. We also do other environmental enrichment, just again, to try to mediate the level of stress as best we can, utilizing our dog appeasing pheromones or DAP, Adaptil, music. So we have a set music schedule of different channels on Sonos. And so we have classical music 5 days a week, And then we have Reggae Tuesdays and Saturdays, because this is where we have the science behind actual calming in shelter dogs, is really behind classical and reggae. And it's quite possible that spa music or other forms of music are also calming on dogs, but this is right now where the science is pointing us. So we try to offer that. If staff members prefer to listen to other music, they are welcome to have earbuds. If they're not into reggae, then they certainly don't have to listen to that. They can have their own earbuds in, but we reserve other genres of music for ourselves, not allowing. I'm sorry, my battery just said it was running low. All right, I fixed it. Sorry about that. Little panic. Okay. Anyways, all right, like I said, our next speaker is going to go much more into detail, but we try to use fear-free color palette, the calming colors that you see on the bottom of your screen. So paint colors that are soothing to animals and to people, and providing frequent enrichment opportunities for them daily. All right, so the other benefit we have in reducing stress that your shelter veterinarians have access to, hopefully, are going to be immediate acting medications that we can give by mouth that are in, our preference is to be anxiolytic, meaning it cuts anxiety, not necessarily tranquilizing. We're not just looking to sedate dogs. We're looking for them to have less anxiety, less stress, less fear, anxiety, stress, one of the tenets of Fear Free. And I remember when I first started helping with dogs in shelters, over 10 years ago. And initially my first thought when someone asked me about putting shelter dogs on medications, I thought, well, I don't want to do that. That's false advertising, that's going to mask their behaviors and adopters won't know what they're really getting. But I'll tell you, in the time that I've spent in shelters since then, is I've discovered that really it's stress that's altering behavior more than an appropriately prescribed medication. We really don't know who these dogs are when they're under a great deal of stress. But if we can alleviate that stress and allow them to show their true behaviors, then I think our adopters have a better chance of seeing what they're actually going to have in a home. And I think it's essential to really have a plan for those medications when the dogs are going home. So we will have a weaning plan set up. It's typed out and it's also on the bottle. And then they have our number if they're having difficulty with the weaning plan. If for some reason, as they wean them off the medications, they're starting to see fear, anxiety, or stress creep up at home, that we have resources for them to help discover why that is, if there's a bigger problem and it wasn't just about a shelter stress. So oral anxiety medications are a useful tool for every veterinarian in a shelter setting. There's lots of behaviors that we may see related to stress, whether it's jumping, barking, mouthing, mounting, all of these kind of what we might refer to as sort of rough and rowdy behaviors. Often those behaviors are not necessarily about training, but they're about displacement of fear, anxiety, and stress. So they're very anxious, they're very stressed about what's going on around them, and they displace that through a number of these, what we would consider undesirable or rough and rowdy behaviors. We can also see dogs that just don't cope well in the kennel situation. They're either bolting to get out or they're refusing to leave because they're too scared to walk on the floors or too scared to go through thresholds. And again, we commonly will see shyness around people, or worst case, we'll see forms of aggression. And that's a whole nother talk, whether we're treating and adopting out aggressive dogs. But certainly if we're seeing dogs who are to the point of being fearful and utilizing growling and other behaviors, medications may help alleviate some of the stress that's behind that. So when do these behaviors actually warrant the use of medications? And I mean, specifically in the shelter for the immediate acting oral medications. And so we use common sense, right? If we see a dog bite a leash once, we're not shouting for trazodone immediately, right? These are behaviors that are occurring more than just a few minutes at a time. that staff members are seeing them repeatedly throughout the day. Potentially they're not happening that long, but they really have strong potential to harm the welfare of either the dogs or the people around them. Or let's say they do it only when someone walks by their kennel. Well, that's really going to hinder their adoption presentation. And it also suggests to me that they might be really stressed in that situation. So we want to help them cope better so that it helps them get the best home possible. And again, just looking at the overall body language or overall picture of a dog that is just repeatedly showing fearful, stressed, anxious body language, that's suggesting poor welfare, then we probably need to use medications to help improve that. And we, as I'll talk about here in a moment, we see dogs consistently demonstrating a fear, anxiety, and stress level above 2. Then that's indicative that there's enough stress that it warrants medication. We will also use oral medications for dogs when we know a stressful day is anticipated. So for example, their day of surgery. And whether this is our in-house dogs, whether it's dogs we're bringing in for our high quality, high volume spay neuter days, we might utilize fear-free, we commonly refer to as pre-visit pharmaceuticals or oral pre-medications. Even if they haven't been showing signs of stress, we know it's going to be a really hard day on them, and we want to try to minimize that and help them cope as best possible. So this is the fear, anxiety, and stress scale coined by Fear-Free. And I love this because it's color coded to kind of give you an idea of when it's okay to move forward with our examinations, our handling, our procedures, and when we want to start to use caution and then potentially just stop what we're doing, take a time out, and rethink our plan. So our green dogs are those showing low signs of fear, anxiety, and stress. So level 0, level 1. So again, they're readily accepting treats, they're interacting, we're not seeing any body language indicative of stress, fairly relaxed or, wiggly body language, loose body language, friendly and interactive. When you move up to the more yellow body language, so moderate fear, anxiety, and stress, these are going to be our dogs with level 2 or level 3. So might be interested in our treats, might be interested in some interaction with us, but a lot of their time, particularly level 3, majority of their time is spent looking for an exit, showing a lot of those displacement behaviors, mouthing, jumping, spinning, panting, fidgeting, like really can't sit still, difficult to handle. And then we get into the red dogs. So these are the dogs that are either, they're in full flight or fight mode at this point, level 4 and level 5. So they're either completely panicked, where they're alligator rolling, they're screaming, they're trying to bolt out of the room, really difficult to touch them, or they're completely shut down. So they're in a frozen state, they're not moving, they're not making eye contact. They really have just gone to an internal happy place. And I think those are the dogs that we often just go ahead and do what we need to do and sort of ignore that those dogs are really in a petrified state. They've just gone into sort of shut down, learned helplessness mode. So it's important to recognize those dogs. If you're seeing that a lot in a shelter setting, like more than just for a physical exam, we really need to rethink whether those dogs should be in that shelter environment at all. And if we have a foster option, try to move forward with that. It's really not humane to have a dog maintained in a persistent level 4 or level 5 fear, anxiety, and stress. Or these are the dogs that are starting to become aggressive, right? They're lunging, they're barking, they're growling, they're trying to bite or biting, heaven forbid. Right? These are dogs where all of the above, we just say time out and let's rethink our plan. And like I said, that rethinking the plan may be also rethinking adaptability if this dog either isn't safe to be handled by the shelter staff or its welfare is so poor that it really isn't humane to keep them there. All right, so what can a shelter veterinarian keep in their pharmacy cabinet? These are the medications that I keep on file here, probably used in frequency from top to bottom, meaning we use trazodone probably the most frequently and acepromazine the least frequently. But again, every dog's an individual and we try to cater a plan based on each dog's individual needs. So I have a lot of details in some of these slides and I'm not going to read them to you. I did include them in the notes so that you have those details to refer to if you need it later. You'll see there's a very wide dose range here. And I just kind of tell people to use the shortcut. So for a dog less than 40 pounds, we might want to calculate a dose between 4 and 6 milligrams per kilogram. But over 40 pounds, we sort of just round to starting at 100 milligrams and then titrating up. I tend not to go higher than 300 milligrams per dose. I just haven't seen a benefit. I've seen more agitation. My colleagues often feel differently, but that's just sort of my guideline and how we practice the GPs. I did want to share this with you as well. So this is our pre-surgical trazodone dosing. So for the day of surgery, either for our in-house dogs or when we bring dogs in to do high quality, high volume spay and neuter, we basically get their weight and we use this chart and we dose them with that. And this is on top of potentially other medications. So these may be dogs in-house who've been with us 3 or 4 days already. We recognized or identified high levels of fear, anxiety, and stress, let's say a few days ago. So they're already on daily anti-anxiety medications like trazodone or clonidine. These medications are at a low enough dose range compared to what we prescribe that it is okay to give them on top of that. So it's just because this day is going to be extra stressful. And if you were already having difficulty coping with this shelter life in general, then the surgery day is going to be even harder on you. So this is an extra dose of medication given on the day of surgery. So some pros and cons of the use of trazodone for shelter dogs. I mean, it's nice that adverse effects are pretty rare. We have a number of published studies, lots of published data specifically on dogs in veterinary settings. We know it's safe even at fairly high doses. It's not controlled, so it's a lot easier for staff to access and distribute to the dogs, right? If you have a controlled substance, you've got your DEA, you've got a log, it's only a certain people in the hospital are able to actually give these medications to shelter dogs. So we really try to avoid having to give out controlled drugs if we can. It's just a can of worms we try to avoid unless the dog absolutely needs it. But again, fairly safe, fairly consistent results that we get with dogs. The cons are that it can take up to 2 full hours to kick in. So if you need something immediate acting, meaning like in the next 30 minutes, trazodone may not be your best first choice for right then. And we also know it may wear off after about 6 to 8 hours. So some of our dogs, if we're doing BID dosing, so kind of breakfast and dinner or early in the morning and in the evening, there's a chunk of time, 3 to 4 hours, where this drug may have worn off. And so you're seeing some rebound for your anxiety and stress in that window. It is also a fairly large bitter pill. So some of our dogs can figure out that it's in there and spit it out. So it does take some creativity, which I will talk about here in a moment. And there are some reports that it may lower the seizure threshold if you have a known epileptic dog. But for the most part, trazodone is very safe. Now, with any psychotropic medication that is hepatically metabolized, you're probably going to find a published report on it causing an idiosyncratic liver issue. There is one published report on one dog having an adverse reaction to trazodone, but for me, I still use it regularly, and we have not had major issues with side effects or liver problems. So our probably next most commonly used medication is clonidine. So clonidine is an alpha-2 agonist, basically slows norepinephrine release in the reticular activating system, which is going to decrease anxiety and alertness. This drug's commonly used in, the most common use in people is going to be for ADHD. It is also a hypotensive agent, meaning it decreases blood pressure, but its main use is for treatment of ADHD in children. And again, this information is included just so you have it in the notes. But side effects, you're likely to see sedation. I will say in most cases, on average, clonidine is a little more sedating than trazodone. We can see some mild hypotension, in the 12+ years I practiced clinical veterinary behavioral medicine. I probably had a couple of dogs have a sort of sudden hypotensive event on clonidine, meaning they sort of fainted from a sudden drop in blood pressure, because this does decrease blood pressure. But again, it's a very rare event, but certainly something to watch for and to keep in mind. And really, with any medication that we use that's affecting the brain, we can certainly see agitation or dogs that just don't have the right reaction, right? That's always possible with any psychotropic medication, but it's pretty rare with clonidine as well, just like trazodone. So the pros of clonidine are that it is a little bit faster acting. We often can see effects starting as early as 30 minutes. I find this has a greater calming effect in hyperkinetic dogs, meaning dogs that are very frenetic, kind of can't sit still, ants in your pants. Clonidine has a greater calming effect than some of our other medications on average. Again, every dog's an individual and can have its own individual response. The cons are that it may be more sedating. And again, like I said, for shelter dogs, we're not looking to knock them out. We don't want them to be sedate. We just want them to be calm. We want them to be their best selves not under the duress of fear, anxiety, and stress. As I talked about, hypotension is certainly possible. And in some dogs, they can burn through this very quickly. So on average, I would say you probably get it to last as long as trazodone, so 6 to 8 hours. But I have had some patients where we feel like it's wearing off after 4. We just metabolize it a little more quickly. And so again, something to watch for and to keep track of in these dogs as you're administering these meds. All right, our next most commonly used medication is going to be gabapentin, which is technically an anticonvulsant, although it's not really used as an anticonvulsant. It doesn't do a great job necessarily. I would say its main use is typically for neuropathic pain. It also has anti-anxiety properties, as does pregabalin, which I don't mention in this talk today because it's only recently become more affordable. But for now, we do use gabapentin quite frequently. It lasts about the same amount of time, 6 to 8 hours as trazodone, maybe in some dogs even 8 to 10. Side effects are not super common other than sedation, more common, and we just watch for any other adverse effects like GI upset or agitation. And I have on occasion seen dogs get the munchies from gabapentin. Actually, it's probably more than just on occasion. So if you're looking to enhance appetite, sometimes this is a good choice. So the pros are that, again, very, very safe. It's sort of self-limiting. So I'm sure you probably noticed my dose on there, 50 milligrams per kilogram. This is pretty high. And that's based on what our neurology department at OSU recommends for dogs that either have a lot of neuropathic pain or whose anxiety is not responsive to the lower doses. It's a bit self-limiting the way the GI tract absorbs it. And so once those receptors for gabapentin are saturated, they can't absorb anymore. So it's really hard for a dog to overdose on gabapentin. So it's very safe, assuming their renal or kidney function is normal, because it's metabolized by the liver and it's excreted from the body through the kidneys. So you need to have good kidneys in order to keep this going. But again, we're talking about the use here in dogs for a short period of time. So we're not typically running blood work unless we have reason to do so or they're geriatric. So again, low side effect profile. It's a 2-for-1 for pain. So for our hip dogs, our back dogs, if we think they might be painful, that might be my first choice of an anti-anxiety med over trazodone, because I might get that 2-for-1 benefit of treating pain as well as treating anxiety. The other benefit is it doesn't have the bitter taste that some of our other medications do. So you can actually open the capsule if needed and mix it with some palatable food for them to eat. The cons are that sometimes the level of sedation is not predictable. So I'll have some dogs that are barely calmed by 40 milligrams per kilogram, and other dogs who are very sedate, which is again unwanted, at 10 milligrams per kilogram. So it's not very predictable and not as consistent as some of our other medications. It's also a little more challenging to give to our itty bitty dogs. So the smallest size capsule is 100 milligrams. So if you have a 4-kilogram Chihuahua, you're going to be using the higher end of the dose range, or you're going to have to look at compounding it. And it's just good to remember that really important to always send home weaning plans for any of these medications, because abrupt discontinuation can not only lead to a rebound of fear, anxiety, and stress, but some of them can also lead to other physical problems. And gabapentin specifically, we can certainly see seizures happen with abrupt discontinuation if it's been given for an extended period of time. I know I did have one patient when I was at Ohio State who would take gabapentin every 8 hours during boarding. And so he was given gabapentin every 8 hours for a week of boarding, came home, abruptly stopped it, and he had a seizure. So certainly, again, just the importance of a weaning plan for all these medications, but particularly gabapentin. So now moving on to clonazepam. So this is a GABA receptor agonist. So basically accentuates the GABA receptors so that opens up and we get a nice influx of negative chloride ions, which should just have that beautiful anxiolytic effect, a true anti-panic effect. This is really the best anti-panic for our dogs who are really panicked, really, really fearful. This can really reach that level of panic more so than the other medications I've discussed. It also has some other properties. So the benzodiazepines, that's the class of drug this is a muscle relaxant. So you can sometimes see ataxia or sort of the drunk walk due to that muscle relaxing effect. This is typically only the first few times you dose the dog if you're dosing them appropriately, but something to watch for. Definitely an appetite stimulant. So if you have dogs that are super anxious, very shut down, not willing to eat, sometimes the use of clonazepam or another benzodiazepine can really help block that panic and help them want to eat. Just be careful because it can really increase appetite in some dogs and make them a little more mouthy and grabby about treats in their food. And it's also an anticonvulsant. Again, typically you think of anticonvulsants and benzodiazepines as the use of sort of Valium or diazepam to stop a seizure. But it is, I state this merely to say it's safe to give in epileptic patients. So other pros of clonazepam, which is a benzodiazepine, and the reason I choose clonazepam to keep in our shelter cabinet is because it's the longest acting. So it's going to last 10 to 12 hours compared to another benzodiazepine such as Valium or Xanax are only going to last a handful of hours. If I'm looking to get coverage all day and all night for a panic for a dog in a shelter, then I want the longest acting one that I can. So clonazepam is what I've chosen and what we've used. So it's the best when it works like it's supposed to. It's the best treatment for panic and profound fear. The increased appetite is helpful for behavior modification because they engage very readily in positive reinforcement training. It has a fairly rapid onset of action. So similar to clonidine, we're seeing effects within about 30 minutes. Again, we have options for durations. If you're, for some reason, are looking just to provide anti-panic for a few hours of time, there are other benzodiazepines that you can use. They're just not highlighted today. And again, safe in epileptic patients. So the con, so this is a big con, is the paradoxical excitation. So I did a retrospective study on use of Valium or diazepam, which is a similar benzodiazepine. And I found 1 out of 3 dogs had some sort of paradoxical excitation response. And by paradoxical excitation, I mean bouncing off the walls, zooming, like they've had 100 cups of coffee, not settling. It's kind of a disaster when that happens. It's temporary, right? It only lasts for the duration of time the drug is in their system. And if needed, we can give other medications to calm them down. But it's certainly a possibility. The other issue is that disinhibition of aggression in dogs is certainly possible. So I'm reluctant to give a benzodiazepine like clonazepam to a dog that is showing any signs of aggression. And what disinhibition means is that a dog who might be fearful and showing more inhibited forms of aggression like freezing, growling, looking away, but not actually biting, under the influence of a benzodiazepine might sort of lose that hold back and actually move towards a bite. So it's not really something I'm looking for a dog to treat aggression. Ataxia, as we talked about, is common, but again, we're not, in a shelter dog, we're trying to use levels that are low and not going to lead to excess sedation or major muscle relaxation. But just be aware the first dose you may see that, and you may need to adjust your dose accordingly. The other thing to think about is that you can have a dependence as well as a tolerance develop with extended use. Now, the hope is that in a shelter dog, this is temporary. This is a few days, a week or two, until we can get them through this situation of extreme stress. Either we're getting them into foster or we found housing or other means for them to cope and adapt to where they are, that they're no longer needing this medication. So we're either weaning them off while in the shelter or we're weaning them off in the home. And again, this is a controlled drug. So it becomes a real pain as far as who can give this drug, who can hold on to this drug. And every state is different, but in Ohio, we have to be a bit strict. So we can only have our veterinarians or veterinary technicians can actually give these to our dogs just based on our pharmacy license. And so that does inhibit. So if we don't have a technician or a veterinarian over a weekend, I'd have to abruptly discontinue this medication over the weekend. So I tend to reserve these for my truly panicked dogs who don't have another choice of foster or adoption in that moment. And it's kind of given for temporary. So the hope is that it's just a few days. I really don't want to send home a controlled drug with a brand new adopter with whom I don't have much of a relationship. So we really try to avoid that and either use it just for a day or two in shelter or have the weaning plan while they're in shelter. All right, so the last oral medication I'll talk about is acepromazine. So acepromazine specifically is a tranquilizer. Most behaviorists do not consider this to be an anxiolytic, it's not an anti-anxiety medication. That said, some of our dogs in certain situations like surgery or having procedures done or their first day or two where they just need to calm down and then we can work on helping them cope better, sometimes we need some of that tranquilization. but we want it to be in addition to medications that are going to treat that anxiety, such as trazodone, clonazepam, gabapentin. I tend not to use it in combination with clonidine just because of the opposing effects on blood pressure. But I know I have colleagues that have done that. So again, it's a tool to have in your toolbox. It's not something I reach for very frequently. These tend to be pretty extreme cases where I need them, or it's where I may use this as post-op. So if we've had an amputation or another orthopedic surgery where a dog isn't coping well and really needs to be calm afterwards, I might add acepromazine to one of these other anxiolytic medications to keep them quiet so that they are not hurting themselves or disrupting their surgery. So again, this information will be included in your notes. The gist of it is that it's a tranquilizer best used in combination with another anxiolytic drug. All right, so the decision tree. So I will be honest, this is the first time I'm sharing this decision-making tree outside of my organization. So I put this together for other veterinarians who were wondering why I was choosing them as I was choosing and how I was making changes when things didn't go the way we thought they would, just using trazodone alone, or why I might choose a different drug than trazodone as my first choice. And so bear with me as I'll try to walk you through this, but it's the first time I'm sharing it. So if there are questions, hopefully you'll put them in the Q&A and I can answer them at the end. And again, this will be included in the notes. Okay, so step one, you've identified a dog has fear, anxiety, and stress that is warranting medication. And you want something immediate acting that we can give in the short term with a weaning plan, right? And so let's say you have a dog that is anxious or maybe agitated, clearly not coping well, and we have no painful conditions going on. There's no hip dysplasia, there's no injury, there's no Lyme disease causing joint issues. They're just anxious and agitated, just plain old fear, anxiety, and stress. I'm probably going to start these dogs on trazodone. And I told you about that shortcut where it's under 40 pounds, 4 to 6 mg per kg, over 40 pounds, start with 100 twice a day. So BID stands for twice a day. And if they're over 70 pounds, then I'll start with 150 milligrams twice a day. So for us, twice a day is breakfast and dinner. We don't have someone who can give medications 24 hours a day. So it's really kind of at the start of the day and at the end of the day. Let's say if I start them on this dose and for some reason they're a lightweight and they seem really sedate, which again is never our goal, then I'm going to cut whatever dose they were on in half. And occasionally we see that some dogs they're very sensitive to the antihistamine effects of trazodone, just like some people are really sensitive to Benadryl and some people, get agitated and hyper on it. Dogs are the same way. So if that happens, I will cut it in half. Well, let's say I start them on, they're 40 pounds and I start them on 100 milligrams. It helps a little bit, but it's not enough. We're still seeing high levels of fear, anxiety, and stress. I might increase by 50 to 100 milligrams per dose each day. So if they're at 100 milligrams and it's not quite enough, the next day I might go to 150 milligrams. Give it a day or two. If that's not quite enough, I'll go to 200. And I'll sort of work my way to a maximum of 300 milligrams per dose. And let's say if I've reached 200 milligrams twice a day for this dog, and it's great. He reaches a nice plane of anti-anxiety without being sedate, but it's wearing off. So I'm giving it at 8 a.m. and by 2 or 3 o'clock in the afternoon, he's back to high fear, anxiety, and stress. So if that's the case, I might then move to TID or every 8-hour dosing. And I'll talk about how we accomplish that without staff in the middle of the night. And so if I do that and it seems to be helpful, then we keep them on that until either if we feel their fear, anxiety, and stress is no longer an issue, we can wean them off in shelter, or we can send them home with a weaning plan. So let's say I started this dog, this 40-pound dog on 100 milligrams, and it did nothing. Like he wasn't better at all, or maybe even he seemed to be worse. I've certainly seen that happen in these dogs where they are more agitated after I start a medication. This is why it's important to keep in touch with your staff members who are with the dogs on a daily basis to tell you if they seem worse. So if that's the case, if it's done nothing at that dose or they seem worse, I'm going to discontinue and I'm going to move to clonidine, which I'll talk about next. So let's say I have my 40-pound dog who I started on 100 milligrams and I worked my way up to 200, 300 milligrams. And it's better, but it's still not enough. This dog's still having breakthrough barking, breakthrough kennel bolting, breakthrough leash biting, mounting. Well, what I might do is say, I don't want to take the trazodone away because it is helping them. I'm going to add, so this is where I get into a polytherapy. So I'm adding clonidine, typically at a very low dose range, so 0.01 to 0.025 milligrams per kilogram at the same time that I'm giving the trazodone. And if it helps again, but not enough, I'm going to go a little higher. The maximum dose of clonidine I'll use is 0.05 mg per kg. And again, if let's say this is helpful, but it's wearing off, then I move to increased frequency of dosing or every 8-hour dosing. Now, because clonidine can wear off, and I have seen some dogs on occasion need it every 4 hours, this is one medication I might do that. Now, I haven't done it yet, but I would if I had to, if it was really to the benefit of that dog. Again, max is every 4 hours. So I don't think I would be giving a dog keep 4 hours in shelter, but maybe every 6. All right, and so if adding clonidine did nothing else or it made them worse, so we had trazodone on board, we tried to add clonidine to make it even better and it made them worse or it didn't help, that's when I might substitute acepromazine with the trazodone. And I will start at the low dose of 1 mg per kg, and if it helps but not enough, I might increase it. So just kind of my decision with the start of trazodone and how I might maximize that dose and how I might also add something to it if necessary. All right, so let's say we have a dog showing not just FAS, but pure panic. So they're hypersalivating, inconsolable, constant vocalization, and they've shown no signs of aggression towards people or dogs. I will probably start with trazodone, but if I'm not seeing some relief like that day, that afternoon, these are the dogs where I might try a benzodiazepine. Again, there's caveats to that. This is just for dogs. If a dog that is inconsolable, hypersalivating, constantly vocalizing, they need help right away. And so I'm probably going to add a benzodiazepine to see if I can get them through their first few days in shelter and then hopefully wean them off. And I will increase that dose if necessary. If they have that paradoxical excitation that I talked about, or if they start to show aggression under the influence of this medication, I'm going to discontinue it. And then what I might do is add gabapentin to my trazodone instead of clonidine, just to get a little bit more sedating and potentially appetite stimulation, which may help them be willing to eat and help adjust to the environment. And so here's my dosing here. And then again, the maximum of gabapentin, even in combination with another medication, it's going to be 50 per kg. So let's say we have a dog that is showing signs of fear, anxiety, and stress, and they also have pain. So whether that's hip dysplasia, back pain, ear pain, you name it, some sort of pain. Even though gabapentin technically is used to treat neuropathic pain, every sensation of pain is being processed through the spinal cord and the brain and the central nervous system. And so if I can help that at all by the use of gabapentin, that's probably going to be my first choice. So here's where I'll just use a monotherapy, so my only medication, no trazodone. I'm just going to reach right for gabapentin as my first choice. And sort of here's my dosing recommendations. And if I start at that lower dose and it helps, but it's not enough, I'm going to increase the dose by 100 milligrams each day. Because again, it comes in 100 milligram or 300 milligram capsules to a max of 50 mg per kg. And if needed, if I find this is helpful, but it's wearing off, as I talked about with the other medications, I'll move to 3 times a day or every 8-hour dosing. And if it does nothing or makes them worse, so I have on occasion started a dog on gabapentin and they get really hyper, they're agitated, they aren't settling very well, I'm going to discontinue it. And then I'll use trazodone as my first choice for monotherapy. Even though I'm not getting that pain relief, just the paradoxical reaction doesn't make it worth it. All right, and so let's say we have a dog showing signs of panic and is showing signs of aggression, so growling. At the same time, I'm probably not going to choose I'm probably not going to choose a benzo right away. So as I talked about in my last slide, dogs that are really panicking, usually clonazepam is my first choice, but they're starting to show some aggression. I'm really hesitant to do that. So I'll probably start with gabapentin. But again, if we're in a critical situation and this dog is not settling and they're in full panic, then I might try clonazepam, but under very closely monitored scenarios. So where we're only having experienced people handle the dog to make sure that we're not seeing any disinhibition of aggression. And again, I will increase the dose as needed as long as we're not seeing major sedation or muscle relaxation. And if we're having negative results, then we're just going to discontinue it. And then I'm just going to go back to trazodone, which is kind of the old standby. I'm just trying to give you examples of situations where I might choose something different than trazodone as my first choice. All right, sorry, that was long-winded and maybe should have just let you read that on your own. But just to kind of see where my mind goes and how I make decisions on which medication to give to which dog. And again, they're each an individual, so we have to make adjustments by closely monitoring them and making changes as needed. All right, so how do we get these dogs to take meds? Typically, we want to coat it in something sticky and then cover that, whether it's peanut butter or easy cheese, and then we cover it in something delicious. We like Braunschweiger a lot, so liverwurst. It's actually lower in calories and fat than peanut butter. And it's very sticky, so it tends to glob onto the pills very well. And then we also will roll it in breadcrumbs, so that if I'm putting it in a time feeder, which I'll show you in a moment, it doesn't stick to it. And B, it puts some texture there. So sometimes we'll crunch Doritos or chips or crackers in there so that they have something textured. Because these dogs who figured out, ooh, there's pills in here, the second they bite into something and feel something hard, they're going to spit it out. But if that something hard that they're feeling also tastes good, they're more likely to keep going if they sense that. And so we keep breadcrumbs with our sticky stuff to roll the pills in. We also do keep pill pockets on hand, and plenty of our dogs will eat pills in pill pockets, no problem. But plenty of them won't. Plenty of them who've chewed through that pill pocket and into trazodone never want to touch a pill pocket again. So we found this sort of method of disguise tend to work a little bit better. We will also use empty gelatin capsules. So we might say something like trazodone, put that in the empty gelatin capsule to protect them from that bitter taste, and then put that capsule through this process of sticky, delicious, and breadcrumbs. So giving meds after hours, or let's say you just don't have staff there even to give twice daily dosing, but your veterinarian has decided that they need to be on a more frequent dosing schedule. And so we ordered time feeders. So these are actually scheduled for dogs to have their food dropped into a bowl. But what we did is we removed the bottom tray where the food's supposed to go in, and we set the whole time feeder up on top of the kennel block, and we move it just to the side so that the treat rolls into the kennel. Now, this will only work if you have either a shelf or you have kennel walls that don't go all the way to the ceiling. So it works well for us because it's high enough that it's out of reach for the dogs. For dogs that are able to kennel jump, we put them in a kennel that has a grate on the top of it, and we would just set the time feeder to drop through the grate. So basically you time it, and you can program it to release every 8 hours. And so we just have every 24 hours, the staff member gets it down, cleans, disinfects, and puts our 3 meatballs in there. And so if we're using peanut butter, Braunschweiger, easy cheese, in 24 hours, there's enough preservatives in there. We haven't had them go bad. You have to be careful though, because if you're using other foods, they can get kind of stinky and gross. We certainly don't want them to get sick or eat anything bad. But usually foods with preservative in them, again, pill pockets. If the dog will eat pill pockets, that's no problem. We've just had a lot of them become wise to those. Again, another reason why the breadcrumbs are helpful, because if this was really sticky, it would go to drop the floor of this section and the pill wouldn't drop. And so breadcrumbs help it roll and drop much more quickly. So this has been a lifesaver for some of our dogs who, when we come in the morning, their fear, anxiety, and stress is through the roof as they're excited and they hear the other dogs barking and they're ready to get out and they're frustrated that they're not the first ones being walked, or they have no medication on board because they haven't received anything for over 12 hours. Well, if we get their meds to drop 2 hours before we're set to come in, they're all in a nice plane of anxiolysis, not feeling high levels of fear, anxiety, and stress, and they're much more patient, and they cope a lot better with that whole morning routine if they've already been given their medication before the daily routine begins. All right, so you notice I didn't mention some of our longer acting daily meds. So your Prozac, your Paxil, Zoloft, Clomicalm. So these are typically medications that a behaviorist is going to prescribe or a veterinarian is going to prescribe for pathological anxiety. So a disorder that persists outside of the shelter environment. And in some cases, these are medications that are going to be lifelong, because these are dogs that have either for a congenital reason or for a trauma reason, or just something happened in their life that they are struggling with anxiety that is outside of the shelter. it may be that they need the assistance of these medications to cope in their home environment for life. And so we don't carry these in our shelter. I have called them into pharmacies for dogs who are in either foster to adopt or are already adopted situations. So we have a family that is bonded, recognizes a dog maybe has a pathology of anxiety or other fear, anxiety, distress disorder, but they're willing to do the work and they want to commit to potentially giving this dog meds for life and to take that on. And they're also committed to doing the behavior modification necessary to go with it. These disorders don't get better just by throwing a pill at it. It's a combination of environmental changes as well as behavior modification. And so if we have a family working directly with a veterinarian or a veterinary behaviorist, then we will recommend the use of longer acting medications. But it's not something, at least so far, I have prescribed for any of our in-house dogs. Okay, so this brings us to, and I'll go through this quickly because we're sort of low on time and it's going to be in the notes, but chemical restraint. So this is different than our oral medications that we're giving, daily for our dogs in-house in the shelter environment. This is for dogs where we have to get something done to them that they're really not happy about. So whether that's an exam, a procedure, or whether it's radiographs, something that's going to be highly stressful for them. And they're either showing those level 4 or 5 fear, anxiety, and distress, or really either it's really inhumane to handle them without sedation, or it's unsafe for us to do so. And so I'm going to walk through a few of the commonly used medications, and you'll have these in your notes, but they're ones that I recommend having in your toolbox. So dexdomitor, dexmedetomidine is basically at higher doses will have a full plane of sedation. It is reversible, so if you need to get something done quickly that requires full sedation, but you only need it for a few minutes, it's great because you can reverse it. They wake up within a few minutes and walk away. Butorphanol or torvegesic is an analgesic or a pain medication, but it does also cause a little bit of CNS depression or calming effects. So it's nice to be given in combination with some of these other meds, and it does provide some pain relief. Ketamine is a full dissociative general anesthetic. So these dogs will be completely out. We typically don't use it alone because they tend to get dysphoric and have some what we call myoclonic jerking and convulsions. So it's usually in combination with dexmedetomidine or other medications. Just remember, one thing I'll point out is that if you are going to give ketamine with dexmedetomidine and you're going to reverse that dexmedetomidine, you might want to wait a little bit because if they just have ketamine on board, it can be a rough wake up for them. So just something to keep in mind. Midazolam is an injectable benzodiazepine. Again, that nice anxiolysis, just complete calm, anti-panic, as well as increase of appetite. But again, midazolam we're usually using in combination with something else for really needing that anti-panic effect. Some of you may have Tilazol in your cabinet. So this is that combination of a benzodiazepine of zolazepam as well as taletamine, which is a general anesthetic like ketamine, but it puts them together. And it comes in a nice vial that you reconstitute and give in a single dose. This works very well if we need full plane of sedation for a procedure. It's just for a very large dog, you may see volume challenges, particularly if this is an injection for a fractious dog where you need to get that injection in very quickly. Sometimes the volume is just too high to go well. All right, alfaxone is one that not everyone has. So this is something, the reason I mention this is that if you have dogs that are geriatric or have cardiac issues, this is a nice one because it does provide that full anesthesia without decreasing their cardiac output. So it's completely safe to give in our cardiac patients. So if we have our geriatric patients, this might be a safer choice. So I recognize that not everyone carries this. It's sometimes harder to find. It is also a bit limited for larger breed dogs. What we tend to do with alfaxone is we give it in combination with other meds so that the volume needed is not quite as high, such as dexmedetomidine, but just something to consider and think about. And so I'll next take you through some of our decision tree with injectables. So let's say we have a young, healthy dog and we need a young, healthy dog and we want to perform a procedure where we need full anesthesia. We're going to use dexmedetomidine plus butorphanol. And I might add ketamine if needed at a range of 2 to 5 mg per kg. If it's a small dog, then I might choose Tilazol instead of those because it gives me that gentle anesthetic as well as that nice calming and muscle relaxation. Let's say we have a dog we need to sedate. It's the first time. It's healthy, but it's very fractious. So it's dangerous to handle, and clearly its fear, anxiety, and stress levels are very high. So I tend to start, if this is the first time and I have a dog who's being fractious, I tend to start between 10 and 20 micrograms per kg, which seems high for a lot of veterinarians. But for dogs that are already willing to use aggression to cope with their fear, anxiety, and stress, using lower doses is likely not to get you very far. So we usually start at this dose range of these two medications. We can use our radiology room or another dark, quiet room if you can find one in your shelter, and just wait for them to succumb to the sedation. So let's say they're not aggressive anymore, but when I go in to start my procedure, whether it's radiographs or toenail trim or ear tympanic membrane examination, and they're starting to fidget and wake up and get upset about it, then I'm going to add another dose of dexmedetomidine, so between 5 and 10 mg per kg, depending on how awake they still are. And I'm going to give them some other time to wait. So let's say I've given my dex ibuprofen, waited 20 minutes in a dark room, and I walk in and the dog's still jumping off and showing aggressive behavior. Well, I'm probably going to max out my dexmedetomidine, and then I'm going to start ketamine, right? So ketamine, again, is that general anesthetic, and it's going to give us a much greater plane of sedation and immobility. And so at this point, if they're still being fractious after that initial dose, we need to add it. So for both these cases, I'm waiting another 20 minutes because it can take that long to reach effect, particularly if they've been agitated. So sitting in the middle of your treatment room with barking dogs and people talking is not going to help you accomplish a plane of sedation. You need to find a quiet, dark room when and wherever possible. All right, so for our first dog where we've only just maxed out our dexmedetomidine, and I'm still not where I need to be, I'm going to get to a maximum on my dexmedetomidine plus start with some ketamine. If I have a dog, my fractious dog is still showing aggression, then I'm going to max out on my ketamine. And so basically, in total, we don't exceed 40 micrograms per kg of dexmedetomidine, and we don't exceed 5 mg per kg of ketamine. So again, just something to have to see. All right, start here, wait, and that's when you know. And then, so if this is a dog that's going to require the same procedure in a day or two, write down what worked for him. Don't go back to the top of your decision tree here. Use what worked. So if you went all the way to having to use 30 micrograms per kilogram dexmedetomidine and 2 mg per kg of ketamine, you're going to start off with that right off the bat because the likelihood of the lower dose working the next time is very low. Okay, and so I have a few other diagrams for you that will be in the notes. I don't need to walk through them here. Again, we might have dogs that are geriatric or debilitated, in which case we aren't going to want to use dexmedetomidine because it does decrease cardiac output. I mean, we will use it if necessary, but if we have other choices, we will use those. So that's where we might choose midazolam and butorphanol, plus or minus 8 promazine. Again, just a few others here. I don't need to read them to you. They'll be in your notes. Oh, and I stuck in some cats here. Sorry, just a bonus for you. It's supposed to be a dog talk. Okay, so I do want to just talk briefly about oral transmucosal sedation. So this is basically where we're applying a medication to their gums, so in their cheek pouch, under their tongue, or on their gums, and it absorbs through the mucosa. So these are medications that if it's swallowed, it doesn't work. It has to go through the mucosa. So for patients where it's difficult for us to give them an intramuscular injection of sedation, because all the previous sedation I talked about were typically given in the muscle. So for a dog that are really touch sensitive, so it's really hard for them to be injected in the muscle, then we prefer potentially to do it transmucosally. This is assuming they allow handling of the mouth, whether this is a known dog and their person can do it, or there's a familiar staff person. So this is a trust thing. We have to make sure this dog isn't going to bite someone when trying to do this. But we do have some dogs that are purely fearful and panicking, and trying to give them injection would just send them through the roof. But they are trusting of people enough that they will allow us to rub medication on their gums. And so what we will do is we will actually take the injectable dexmedetomidine, so what I talked about using in those previous decision trees, and we will give it to them on the gum. So we typically need to add honey or maple syrup to add some viscosity so it doesn't squirt all over the floor or get swallowed. And then we just gradually allow more to be absorbable time. What we can also do is we can mix this medication, so the injectable medication, with something like peanut butter or something very sticky that we then smear all over a large surface, like a large stainless steel dog bowl. And then as they're licking it, the hope is that there's enough contact time with the mucosal surface for it to take effect. But what I will say is you end up wasting a lot of medication, and dexmedetomidine isn't cheap. And in most cases, even if you are able to give it through the gums, you're still probably going to have to follow up with an intramuscular dose once they've achieved a level of sedation. And we just reverse it with half the volume that we used compared to this injectable, you use a full volume of atipamezole reversal. There's just something to take note of. Again, a decision tree, if you are going to use the oral transmucosal mount, we do start right off the bat with 40 micrograms per kilogram. Again, because most of it is not actually absorbed. And it's a much slower process when it is absorbed through the mucosa as opposed to in the muscle. And then we add, it takes a long time. So this is not really a practical approach unless you have a lot of time for someone to sit with this dog and monitor and wait. But in some cases, this is the only way we're going to be able to get anything done procedure-wise. And if this is the best choice for that dog, that's what we'll do. And just remember, if you're combining it with morphine, you might see vomiting. All right, so I sometimes get in trouble when I mention this medication because it is an equine drug. This is a horse medication called dermosidone gel. So it is detomidine, which is essentially identical to dexmedetomidine. It's a much higher concentration. So this is a gel that is intended for use on the gums. So it's used in horses. You give it to any of you who have horses have probably used this before when the farrier is coming out or the vet is coming out. It helps get them in a nice plane of kind of less anxiety, less stress, and a high level of sedation. We have used it a lot for our euthanasias. So for a dog where I don't want to stress them out with an injection, but they are, tolerant of having someone touch their mouth, I will put this gel. You need to wear gloves because it can't absorb through your skin. I'll put it on my gloves, maybe with some peanut butter, so they're licking one part of my hand or licking the other hand, and I'm smearing it on their gums. They're in their cheek pouch. We have also used it on occasion for dogs that are going to recover. And so the dose we'll use is 220 micrograms per kilogram. So some of the veterinarians at Ohio State were starting to do this, with a lot of owner discussion clearly, and consent, because this isn't labeled for dogs in the slightest. So this is very extra off-label species wise. But it is a tool because, as I said, when you're using the injectable dexmedetomidine, you're having to use 40 mics per kg. It gets everywhere. It's very expensive and it's not well absorbed, whereas this tends to be very well absorbed and can really, euthanasia is the main reason we use it. It really can give a very peaceful, a peaceful ending. It just helps the whole process just be so much more peaceful for them because it does achieve a much greater level of sedation in something that's not an actual injection. So just to talk about our euthanasia, we, sadly, all of us are in shelters because we want to save lives, but there are cases either for welfare, health, or safety of the community, we do have to choose euthanasia. And so we have a setup where we really try to make sure it is just the most peaceful process as possible. And so we'll use PVPs or pre-visit pharmaceuticals, so the oral medications at least 2 hours prior to our getting them out of kennel and handling them in anything that's going to cause any amount of distress. And I will prescribe this based on how much stress I know this is going to cause them. And so minimal distress, lower dose of trazodone, moderate distress, trazodone plus clonidine, severe distress, all of the above plus gabapentin. I will throw the pharmacy at them. This is potentially, I don't want euthanasia to be stressful on the dog. I want them to be peaceful. I want them to be loose and relaxed. And so I will use whatever medication is necessary to achieve that. And then 30 minutes prior to getting them out and handling them in any way that might cause distress, if this is a dog that really is going to struggle, then I might add the gel. Again, assuming it's safe for someone to be close to their mouth. And some dogs aren't, and we can't use this. But for the dogs that have someone they know or they trust there and will allow them to give this, it can really just make the whole process so much more smoother. So then for injectable, I've shown a couple protocols here. So typically at GG's, what we do, minimally stressed dogs are using the lower doses of dexmedetomidine plus torb. Moderate stress, I'm going higher, and severe distress, I'm probably starting at 30 to 40. micrograms per kg of dexmedetomidine plus ketamine butorphanol. And if I'm not going to wait and see for euthanasia, I probably will err on the side of going higher just to try to minimize any fear, anxiety, and distress that they might have on that day. And then I'm just sharing here, Lap of Love is a home euthanasia service. We have one in Columbus, Ohio. I do feel like, I'm not sure where all their locations are, but they have this protocol here that actually does not include dexmedetomidine. The problem with dexmedetomidine for euthanasia is it does cause vasoconstriction, which can make venipuncture sometimes a little more challenging. And so their protocol actually avoids that. So venipuncture isn't a problem. The veins are not constricted nor collapsed. So I share this with you. I have not had experience yet, but I'm sharing with you because I've learned about it, and we plan to start using that if necessary, just to preserve the veins of the dogs so that venipuncture is easier. All right, so how do we give injections safely? So as I mentioned, it's nice when we can use that dexmedetomidine gel so that we don't have to give them an injection that might be ouchy for them. Ideally, if this is a fractious dog that we're having to euthanize, they should be muzzled. And even after the sedation, sometimes they can come out of sedation and bite in an instant. And so what we might do is, have them use the muzzle like a food bowl, let them eat. We get the muzzle snap and we kind of sneak a little, oops, what was that? Little bee sting injection. And that way, if they get upset, they're muzzled and no one's hurt. There are situations though where we can't muzzle. It's not safe to muzzle them. It's actually more dangerous for the handle to attempt that. And so what we'll do is a drive-by, we call it drive-by sedation with an extension set. So this is where you really need an experienced handler to use defensive dog handling to make sure no one's getting bit during this procedure. I have an example here. It's not the best video, but at least shows my handler here is very experienced. So she has palatable food here and we're walking outside, plenty of distractions, fresh air, beautiful scenery. The dog is eating food. Again, this is what we use if we need to sedate, whether it's for euthanasia, whether it's for a procedure, for radiographs. If the dog gets fractious with veterinary handling and we can't muzzle it, this is what we'll do. And then our second clinician will just be walking outside and have the sedation actually drawn up and then into a butterfly catheter or extension set so that there's distance between the person giving the injection and the dog, which you'll see here. We really strive to have them eating and distracted the whole time, but he did turn afterwards. So you'll see that, play it again. Being distracted, the Paxil injection basically gets it in. So you can see she's pulled away and the needle's out. She had given the whole, I think it was 30 micrograms per kilogram. So she'd given the whole dose just like that, very quickly. And also you'll see as he's turning around, potentially going to lunge for her, she's already backing away from the dog because that extension set gave her additional space. All right, and then once we get the injection into them, we want to try to achieve and maintain adequate sedation so that we can get our procedure done in a manner that's quick, efficient, and doesn't cause fear, anxiety, and stress. So we try to find our quiet room. If needed, if it's still loud, we can put cotton balls in the ears of the dogs. Just make sure you're counting so you know how many to fish out in the end. We'll use a calming cap or a thunder cap to cover their eyes so that the less stimuli getting in, the more they can just fall into that level of sedation. We'll use white noise, that sound, to block out sounds of dogs barking or people talking that might pull them out of sedation. You'll see a lot of these dogs that seem like they're almost sedate, and then someone does a loud laugh or a dog barks and they kind of just perk up and it takes them 5-10 minutes to settle back down. And so if we can block out those noises, that's very helpful. We'll also use classical music in the room to help them achieve a level of relaxation. It's also helpful for the humans just to have kind of calm, soothing music because tension can be high when you're trying to handle a dog that's either fractious or extremely fearful. And then minimize how much we're touching them. I think our tendency is to want to pet and to stroke to calm a dog down, but often that's kind of keeping them awake and aware. So potentially using our touch gradient and gentle control, which Jessica will talk about next, that we have a hand on the dog and we keep it there and we minimize how much we're moving. And we're avoiding this touch and stop, touch and stop. We're going to have a hand on the dog. It's minimal or it's going to be constant so that the dog can habituate to it and not be stimulated and wake up from it. All right, this concludes my presentation. And I wasn't quite sure what time I started, but I know I've run over time, probably a couple minutes. So I don't know if there are any great burning questions from the Q&A that I can answer.
There aren't any questions so far, but if you do have questions, please put them in the chat or the Q&A now.
Okay. Great. Thank you. Have I ever seen trazodone causing bloody stool? Great question. I have not seen trazodone cause bloody stool. I have seen trazodone cause or exacerbate urinary incontinence, but I've not seen it cause bloody stool. I've seen it cause diarrhea. So I suppose if the dog was very sensitive and developed diarrhea, and as that progressed, it caused bloody stool, I certainly think that's possible. But just causing GI bleeding, no, like a Rimadyl or an NSAID would do. No, I haven't seen that with any regularity. Margie says, how many days of meds should we send home on the weaning plan? Gosh, so that's where I need another decision tree, and I just don't have time for it today. So this depends on how long the dog's been on them. So, and how confident I am that this dog is going to adjust very quickly and do well in a new home. So typically it's a minimum of 3 to 6 days. So if they're on, say, let's say they're on 100 milligrams, the fastest weaning plan I'll do if they're on 100 milligrams BID in shelter, I'll do 100 milligrams BID for 3 days, 50 milligrams BID for 3 days, 25 milligrams BID for 3 days, and be done. So that's 9. So probably 9 days is probably our minimum. But if I have them on a polytherapy, if they're on more than one, I tend to wean one and then the other. So that may be putting us at the 2-week phase. It really just depends. If it's a dog who's been in our shelter for several weeks and required the use of anti-anxiety medication, it's going to be longer because I really want to make sure that they have time to adjust, because it's such a bigger change for them to go from a shelter for 4 weeks to then being in a home compared to a dog who's only in the shelter for 2 or 3 days. So dogs that have been on it longer term, or I'm a little more concerned, might have some residual anxiety in the home. I might stretch that to they stay on what they were on for maybe 5 to 7 days instead of just 3 days. And then I sort of cut that dose in half or by 20% every 5 to 7 days. So I'm typically making a drop anywhere between as fast as 3 days and as long as 7 days before I start to decrease a dose. Great question though. We don't wean gabapentin after 14 days of use, should we? Or at what point would you start a weaning plan? So, and I'm going to say this is just my clinical bias because I had that patient who had seizures after 7 days. So I do a weaning plan. It can be fast, right? So it could be over 3 days if you had to be, but I would just try to make it so that it's coming down if possible. And let's say they've only been on 100 milligrams BID, maybe just doing 100 milligrams in the morning only for a few days. But I would say at 7 days is sort of where 5 to 7. I'd even do weaning on a 5-day one, just to be honest, because I also feel like if you've been using gabapentin in the shelter for your anxiety and stress, the transition, although it should be wonderful and they're getting food and love and shelter and structure and predictability, it's still a major change. And so if I can just give them a little bit of help to make that adjustment as smooth as possible, I will. So I think weaning plans are beneficial, not just to prevent withdrawal, but also just to help that adjustment period go better. The question was for both dogs and cats. So our shelter, we only do dogs. And with cats, I would just imagine, do you have access to a weaning plan? So if it's been more than 5 to 7 days, and you're using 100 milligrams, and you're having to look at compounding. So what I might do in that situation is, instead of doing twice a day, just go to once a day for a cat, and then discontinue it. So rather than just abruptly stopping it altogether if they've been on it longer than 5 to 7 days. I hope that answers your question. Again, we don't do cats at our shelter, it's just dogs. But I imagine if I were prescribing for cats, I'd probably still do that.
And then Megan, I think there was one question just before that, and that can be our final question.
Sure. We have a high anxiety dog at our shelter that I've started running a couple miles with on my lunch break. Will and how will any of these drug protocols affect that routine? Oh gosh, that's wonderful. I would hope that we're able to provide exercise and other stimulation while on these medications. So if you're using these medications and that dog doesn't want to go for a run anymore, it's not the right protocol, right? So what I have found is that for dogs like this, that we're finding we have to run for an hour to get them to any sense of calm, is that they're resetting their anxieties back within 30 minutes. What I find is that on the proper protocol, that dog is going to be very responsive to exercise. So should, like a normal dog, after running a few miles over an hour, is going to lie flat out and be completely relaxed and comatose for several hours, right? So what the meds should do is allow him to be exercise responsive. And if he's not wanting to run, then it's not the right protocol. Again, the goal is not sedation. And so I would say if he's on trazodone already and you take him for a run, he doesn't want to go, we might need to adjust it a little bit, right? And again, it's a whole conversation of how is he coping in the shelter? Does he seem sedate? Does he seem listless? In which case we probably want to adjust the dose down. But if he's coping really great and just wants to run for 1 mile and not 2 and wants to walk the rest, maybe that's not the end of the world if he's really coping very well in shelter. But I would say that you shouldn't need to alter what you're doing. He may not need to go running for that long when his anxiety is being helped through medication, but the hope is that you could still enjoy that time with him, and he would just probably benefit even more because he's in a state where he can actually benefit from the exercise. Okay, I think that's it for me. Thank you for listening. And like I said, a lot of what I talked about is in the notes, all the numbers and protocols. So if I went kind of speedy, hopefully you have it there.
All right, thank you so much, Megan, for presenting. And as Megan said, we will share the notes with you after the webinar this evening. We'll be sharing it later this week. So you will have all of that information. So next up, we have Jessica Benoit, who will be presenting Fear Free in Action. And I just want to remind everybody, I'm going to pop that sign-in sheet one more time into the chat. So if you have not signed in already, please make sure you do so that you can receive your credits.
Hi, everybody. So I'm going to share my screen here, get this open. Here we go. There we are. So a little bit about myself. I am a registered veterinary technologist. I am in Alberta in Canada. I own a fear-free certified practice here with my husband, who's a veterinarian, and I have a veterinary technician specialty in behavior and a Karen Pryor Academy graduate, and I'm a certified professional dog trainer as well. So, and I'm fear-free certified. So as a trainer and a veterinary professional, and the avian certification as well, because I have chickens that I love. So we are going to essentially go through what fear-free is, and whether you're working in a shelter, whether you're one of the clinics that works with a shelter. This is kind of what fear-free is about, and really the basics of how we handle patients, regardless of whether they're in our practice, they're in a shelter environment, using considered approach and gentle control, and how to go using distraction techniques for different procedures. We're going to talk a little bit about needs versus wants, and when to stop. And kind of when we stop is when we decide, what Dr. Heron has just been discussing is kind of what pre-visit pharmaceuticals do we need, and do we also need sedation? And we're going to go through that. And so first and foremost, we need to understand stress. And so stress is caused by stressors, so triggers, things that can disrupt normal body function. And so it's not always maladaptive, but we should be seeing our patients, if they are becoming stressed, recover quickly and return to baseline. And then the other concern is that some of these triggers and stressors do cause fear and anxiety and stress. And if we are dealing with that long term, then we are having difficulty with our patients' health and our well-being. And we know for our shelter animals, depending on how long they're in the shelter and how stressful it is even being admitted into the shelter and all those sorts of changes, on top of needing medical care, we really need to be mindful of the fear, anxiety, and stress that's going to occur now when they have to interact with veterinary professionals and the veterinary staff. And so I could do a whole presentation on canine and feline body language. And so I'm going to make this brief, but essentially, when we're looking at our relaxed dogs, we have open mouths, ears forward, tails are often midline with the body, and they're loosely wagging kind of back and forth. And when we think of very relaxed dogs, I think often we think of our happy labs and our golden retrievers, and we have mouths open, soft faces. When we are looking at a patient that's stressed, ears back, tail tucked, they're usually crouched, they're trying to hide or get small. You're going to see a wrinkled brow and a lot more tension than you do with our relaxed dogs. For our feline patients, their tails are usually not close to their body, they're relaxed, their pupils are not dilated. We're having an almond shape, ears forward, whiskers kind of forward. They might be gently and calmly blinking. Whereas when we're looking at our stressed cats, and often cats in shelter environments and clinic environments are hiding. And if given the opportunity, and they should have the opportunity in their kennels, housing spaces, to have places to kind of hide so they can become more comfortable. But we are looking at ears back or ears sideways. Their tails are tucked really close to their bodies. Often we'll call them loaf cats. They look like little loaves of bread. Their pupils are dilated. And we, once again, just like our dogs, they're trying to get as small as possible. These are cats that are feeling uncomfortable. They're feeling fearful. They're feeling anxious. And then on top of that, you're looking for other signs of stress when we're working with animals. So panting, yawning, lip licking, and your lip licking happens quickly. So sometimes it's a little bit hard to see, but it happens in dogs and in cats. We're going to see them averting gaze. They'll kind of look away, pretend that you don't exist. You see that in a lot of social media posts, actually, where people are hugging the animal, children in particular, and you kind of see the dog look away. Their mouths are closed and tight. In our practices, we are seeing these patients are resisting restraint. They're not wanting to take food. And these are indicators to us that we need to do something differently. And so we're going to talk about those things. We're going to talk about what we can do to decrease their FAS, their fear, anxiety, and stress, and how we approach patients, how we approach kennels to make sure that they're comfortable. So with considered approach, what we are looking at essentially is not a frontal approach. We don't want to be coming over top of these animals. We don't want to be reaching our hands over top. We want to approach from the side. If you feel it's safe to do so, crouching down. And often I tell people, if the dog or cat wants to see you, they're going to come to you. In a veterinary setting, we don't always have that time to wait for them to acclimate and to kind of come to us. And so often tossing treats in their general direction can help teach them to make a positive association with our presence. And also it gives us a gauge as to whether they want to approach us or not. And so approaching sideways is really important, and trying not to lean over our patients too much. This is a nice video. This is Debbie Martin. She's a veterinary technician specialist as well. There's no sound in this video, but you're going to see her crouching down sideways to the patient. And this dog is willing to take food from her hand. And so she's feeding it from her hand. But often if we maybe go to retrieve a dog from a kennel, or we are having to remove them from their owners, they aren't always as willing to approach. And so what I recommend is not holding food hostage, is what I call it. And so toss your treats, toss it away. And when the animal gets comfortable, they'll start coming to you. But often it can cause a lot of conflict in our patients, both cats and dogs, if they're food motivated and they really want the food, but they have to get the food from the scary person. And so when we first kind of are introducing ourselves and meeting these patients, it can be beneficial to do that quite slowly. and allow them to kind of take food at their own pace and not necessarily have to get it from you. So gentle control, when I talk about gentle control, I often discuss it as keeping the patient stable and in a position that they're comfortable in as best we can. And I know that we cannot do all of our veterinary procedures with our patients in a position that's perfect for them. But when we are using gentle control, we are really just safely positioning the patient to get the procedure done. In this video, I am very pregnant, but I am crouched down on the ground, so I am using considerate approach. I have actually what you're going to see is a tongue depressor in my mouth, which I'm not necessarily recommending. But what we did with this patient is initially I thought this patient really would prefer my Cheese Whiz on a tongue depressor. But this patient actually preferred liver treats. And when we go into the emotional record, and we're kind of going to talk about that a little bit, not too much. I'll know that for next time. But this patient wanted the liver treats. And so all we had to do for gentle control is what you're going to see in this video here. And so at the beginning of, here, I'm just still talking to her. I'm giving her a lot of verbal praise as well. But what happened actually at the beginning of this video is when I tried to use the tongue depressor with the Cheese Whiz, she moved. She said, no, thank you. And rather than me kind of deciding, well, now I've got to get a little bit more forceful, we just changed reinforcement. I just found something that was more motivating for her. And we're going to talk about treats and kind of how to figure that out. With touch gradient, we really want to avoid sporadic touching. And so touch gradient is when once you've kind of initiated contact, you continue to keep your hands on those animals and glide from one point to the next whenever possible. Sporadic touching causes stress. And when we can glide from one point to another, we're going to decrease their stress. And we know that kind of gliding and stroking is much more calming for the majority of patients. We also need to consider, and when we're working with animals that we may not have a history on, like in the shelter, we need to vaguely kind of decide what's least stressful and what's most stressful. For the majority of animals, dogs and cats, it's least stressful to be starting with their backs and their shoulder and neck area. And then we find that tails and bums are more stressful. Paws have a lot of touch receptors, they're fairly sensitive, as well as mouths and face and kind of head exams. And so when we start touch gradient, we're just going to start touching and just paying very close attention to body language, seeing if our touch is increasing their fear, anxiety, and stress, and then proceed from there. But we really want to be starting with the least sensitive area. And often we're considering what the patient is being seen for as well. If they have a sore back, we're probably not going to start there. We're going to start at a different part of their body. Where does your patient prefer to be? So are we able to do some of our care in their kennel? Are we able to do it in a staff member's arms? If there is an owner present, depending on the situation, can they be with their owner? Because we have studies that show that continuing to keep our patients with their people decreases their stress. And so if that's possible, this is something that we should be able to do. We need to be mindful that dogs do prefer to be on the ground. I know that for certain procedures, it's sometimes easier to have them up onto a table. But with really big dogs, they get really stressed being picked up and placed on a table. So when we can avoid it, we should be keeping them on the floor. Most cats do prefer elevated spaces, but we need to look at them individually when given the opportunity. And so we need to decide how to set up our environment first before we even start really handling our patients. So what are we going to do? We are going to have calming music, and Dr. Heron talked a little bit about that as well. Having that in our surgical wards, having it in our kennel, in our hospitalization wards, in our long-term care facilities where these patients are staying in the shelters, having non-slip surfaces that's in their kennels, that's in the kennels in the clinic. If you're in an exam room, having a non-slip surface on the floor or on the table is absolutely recommended. And it is really one of those easy fixes. We use a lot of bath mats with sticky bottoms or yoga mats. Those tend to be the two things that we use the most. And these metal surfaces are cold and they're slippery. And so they are going to increase stress. And so covering them makes things much easier for our patients. Using pheromones is recommended. So we have Feel Away, we have Adaptil. This can be sprayed onto a bandana. It can be placed onto the mats. We spray all of our feline mats in the mornings, and those are used for kennels, for exams, for whatever we need them for, but we have them, and it lasts, once you spray about 8 to 10 pumps, it lasts about 4 to 6 hours. So sometimes during the lunch hour, we'll do it again. And having a volunteer do that, having a kennel assistant do that is often very helpful as well. So having treats and equipment ready to go, and I say this because so many of our patients learn very, very quickly that the more staff members that show up equals bad things are going to happen. And so unfortunately, it can just be as simple as having a second staff member in to help restrain maybe, or to dispense food, and you will absolutely see that patient's stress increase. I have seen it. I see it time and time again. And so we really, if we have everything ready and we have all our team members kind of there at the beginning, then we don't have to continuously have people kind of coming in and out and increasing that stress for our patients as well. Blocking visual access to stressors is really, really important, especially in a shelter environment, as well as all the sounds, right? There's sounds, sights, and smells. Those are kind of the big three stressors for a lot of these patients. And so blocking visual access is as simple as placing a towel over top of a kennel door, using the plastic sheets that you can buy here. I'm in Canada. We can buy them at Home Depot, and we cut those. You can use those. We've used garbage bags, and just black garbage bags, and just taped them to the bottom half of kennels when required, especially if you have kennels facing one another. It's really good if you can block that kind of access for your patients to decrease their stress. Dr. Heron did talk as well about color palette, and a lot of the pastels and the soft colors are recommended if it's something that you can do. So we really want to be building a strong positive association, and that's with the sights that these animals are seeing, the sounds, the veterinary staff, any volunteers. And so we do that generally with food when we can. And so food is a primary reinforcer. Animals need it to survive. And that's why it is so motivating. That's why it's very reinforcing for them. When we're looking at non-food distraction, toys can help. I have trouble often with toys and veterinary procedures, but wands do work well with kittens and cats. It's just that you have to, for example, do part of your physical exam usually, and then allow them to play, give them a little play break, and then start again, unless your vet is very stealthy and can kind of move with your patient. And that can be a little bit tricky. I find brushing works really well for both cats and dogs, but a lot of our feline patients love to be brushed, and it keeps them stationary, which can be a little bit easier when we are doing different procedures. Petting and verbal praise, and that generally I find is going to be more reinforcing if it's coming from an owner, and we don't always have that option in a shelter environment. It doesn't mean that you shouldn't try and see if it decreases your patient's fear, anxiety, and stress. But that's generally where that bond is, and they have that relationship with their owners. So what we're doing is, this is a video here of a nail trim in our practice. This dog, we tried to give this dog treats the first few nail trims, and she just wasn't into it. And then finally we talked to her owner a little bit about it, and she said, oh, she really likes being brushed. So this is her getting brushes and head scratches while we trim her nails. You also can see my technologist there doing gymnastics and she's upside down, ensuring that patient's comfortable on the floor, because that's what makes her happiest. So for food distraction, when we're using food distraction, that is done before, during, and after the procedure. When we're using it before, we're kind of testing it out. I want to see, does the patient want this? Is the hot dogs going to cut it today? Or do we need to move to the whipped cream? Or do we need to move to the cheese whiz? These are food distractions for patients that are willing to accept food. They're patients that want to come up to you, that are interested in interacting with you. If they briefly stop eating, they're going to start eating again. So these are the patients that food distraction works really well for. Often, when we go to touch these patients and we're just starting with our touch gradient and we're feeding at the same time, we're testing to see that once I start touching you, are you still willing to eat? Because that lets us know that their fear, anxiety, and stress is pretty low, and we can continue with whatever is necessary. So this is an adorable video. And so I just have to show it to you guys. This is a litter of black labs. They all decided they would like the cheese whiz at one time. And we freeze those sticks. So we just cover them. It's adorable. We put the cheese whiz on the tongue depressor, and then we wrap it in saran wrap and we put it in the freezer. And we have a few other high value things, but that's one of our bigger ones. So here's some treat ideas for dogs and cats. So we use a ton of liver treats, a lot of Benny Bullies, hot dogs. We have wonderful, we call them TAs, so kennel assistants or technologist assistants, veterinary medical assistants, and they do a lot of our food prep for our treats. And so the cheese whiz sticks, sometimes we'll have boiled chicken, and we'll just put a lot of this stuff in the freezer, and we can take it out as needed. The Kong Easy Squeeze works really well. And we do have chicken broth popsicles, and we use those more so for our patients for sedation, for anesthetic, and also for ones that might be not feeling, they might have a little bit of vomiting or diarrhea, and we don't want to make things worse, but they're still interested in eating. And obviously not all those patients are interested in eating, and that's where the rest of our environmental setup and our considerate approach and our gentle control and our touch gradient matters as well. Cats, we've got a lot of whipped cream eating cats that love whipped cream. The churro paste, as well as Cat It, is another brand. Those are just the yogurt tubes that have the delicious stuff. Sardine paste works really well. That's the creamy lickables. We do have some cans of tuna in our practice as well. We hide them in the freezer and kind of pull them out as needed. We have Temptations. We've got the hard treats, and then cream cheese as well. So these are some tools that we tend to use when we're using food as distraction. I love licky mats. There's this little orange one at the bottom here that you guys can see. It's just suctioned to the wall. It can suction to the exam table. It suctions to the area where the scale is. You can just smear food inside there, and you could put it in the freezer as well, so it lasts a little bit longer if needed. And then those little the green sticky bones, we use those as well. Pretzel sticks. I have the wooden spoons, and we have them for the patients that are a little bit more fearful. And so sometimes it just gives us that distance and it makes them more comfortable. It also can make us more comfortable depending on if we're dealing with any sort of defensive behaviors. And then we have syringes. We put a lot of AD in particular in syringes for kitty cats, or if you have your hypoallergenic patients that you need to be a little bit more careful with. So this is a scale that's set up, and ideally your treats are just really easily accessible so that we're not pulling patients onto the scale and then trying to get the treats afterwards. And I have a video of a demonstration on luring a dog onto a scale.
So there's two options. If there's not any dogs around, the proper
So this video was done for puppy class clients actually. And so you can body block the dogs kind of from the side, which is what I do when I start walking him on. And then if they're trying to bolt off the front, sometimes if you step in front and you have food right there, that can prevent them from doing so. We have a bath mat on this scale. There should be a mat on every scale. Cat scale, dog scale, it just makes things much more easier for them and much more comfortable. I have had, you know, where the owner holds the animal and then we weigh the owner, and you can do that in certain situations that are a little bit more emergent. But ideally we give them an option, or if we need, if they're going to be more comfortable kind of once they've acclimated and a weight isn't necessary, then we can kind of come back and weigh them after. This is our cat scale. We use a litter box, and then we put a blanket in it and then some treats in there. And you can do the same thing. You can lure your cats in to a litter box or onto a scale, the exact same as you do your dogs. If you're not, in this case, we're using a litter box. If you're using, you can weigh their kennel with them in it as well if they're more comfortable doing that. So as far as kennel safety goes, we want to be taking kennels apart if we do not have a patient that's willing to come out on their own. And so if you're doing this and you can see these cats in these kennels, and if they're already at the back of the kennel and they're fearful, maybe they're hissing, you need to be prepared to have a towel that's going to cover the bottom so that they're more comfortable and everybody is also safe. But that's, sometimes you pull the lids off and the cat pops up and is checking things out and is looking around and is much more comfortable. So this is just a video of how to take a carrier apart, as opposed to opening the carrier and reaching in and pulling the cat out or dumping the cat out, which is really going to increase their stress. And if that's one of the first things that you have to do with them as a veterinary staff member, that may set the tone for the rest of their experience. So we really want to set them up from the beginning if we can help it. And so sometimes we have like the screw ones. This is one of the snap ones. And then just be very careful. Yeah, this cat is having a great time, but be very careful when you go to take the lid off that you're holding the door, because sometimes the door can fall and make a very loud noise and be startling. If you need to lure a cat out of a kennel, this is a video on doing that. I have cats that prefer to some that want to do this on the floor. And if you are taking a history, for example, or you have a few things that you need to do before you're going to be working with that patient, and you're in a room, you have the option to be in a room, or they're going to have a kennel in a kennel, you can just open the door, sprinkle some treats out, see if they want to come out on their own terms. Otherwise, this cat, after we took this video, went on a diet, so you don't need to worry about that. But this is a video of luring. And this is a really beautiful video using considerate approach with a slip lead, using treats, coming up to that kennel, feed, 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 feed. We should be doing this with all of our patients so that the approach of the person predicts that something good is going to happen. And with our shelter dogs and cats, that also makes them much more adoptable, right? When somebody walks by, takes a look into the kennel, and they're happy to see them there. And so this, in this video, she does a wonderful job approaching, feeding, and then feeding through the slip lead. And then she does that same sort of kissy noise that I make when I'm trying to get a dog's attention or a cat's attention. And it helps just guide the dog along. And having that food lure to transfer and transport animals is a wonderful idea. Often when you have to move a shelter animal in particular from one point to another, having food available, because sometimes, there's lots of traffic, there's people, there's other dogs, and there's loud sounds. And so having food readily available and also being mindful and able to kind of body block if need be with a passing dog or a passing staff member is really beneficial. Oops. So distraction for physical exams. We're going to go through just a couple videos of what that looks like. And that's a little licky mat in this picture, and the cat is having her physical exam. That's Lily. She also came out of the kennel like a willing participant. I really like this video because I think sometimes fear-free might come across like, oh, it's all food and we're just placing treats in their face constantly. And that's really not what we're doing. This is a beautiful video of using a towel. This patient did get upset, and then being able to decrease the cat's fear, anxiety, and stress, and still be able to use food distraction eventually once the cat is more calm. And so what's really nice is that the towel was implemented, but she was still, Dr. Rodosto was still able to work around the cat and still do a physical exam with that towel present. This is a dog having a physical exam using food distraction. You see a really good touch gradient in this video. Considerate approach. The vet is down and so is the assistant. Not leaning over the dog. And he kind of moves with the dog. And you see the scratching as well. He still has his hand on the dog after he takes his stethoscope off. That's my staff. And really nice. So when he goes to examine the paws, he glides first from the shoulder down to the paw rather than just kind of grabbing the paw and looking. And that would startle the majority of dogs. And when we think about paws, we know nail trims can cause a lot of stress and there's so much sensitivity in their paws. So being able to kind of glide from a least stressful area to a more stressful area and then examining works beautifully with this dog. So when we need to use restraint, and we absolutely do, it's just a matter of not being forceful with our restraint. And if we're feeling like we're having to use more force, then I think that's the time to really stop and pause and reassess the situation and decide what to do going forward, and whether that's kind of PVPs, and we're going to talk a little bit about changing environment and that sort of thing. So other considerations. But when we are using restraint, we're using 2 stabilizing hands. We do not want more than 2 struggles for our cats or 3 struggles for our dogs. And this also does depend on the position that they have been placed in. So keep in mind, we always want to be, when we're going to do restraint, we're going to be using considerate approach. We're using gentle control. We're using touch gradient like we've seen and like we've talked about. We can absolutely use towel wrap techniques. Dr. Sophia Yin has wonderful towel wrap techniques that she had made public in her courses and her book. And so using towel wrap techniques, absolutely. But when we're using the towels, when we're using restraint, when we're using all of these approaches, we need to be watching body language all the time, right? We need to be seeing, is this increasing fear, anxiety, and stress, or is this decreasing fear, anxiety, and stress? Because I have seen towels used with the best of intentions, but then we see an increase in fear, anxiety, and stress. And are we using, when we're using restraint, are we using treats or other motivators? Are we also petting? Are we brushing? Are we using verbal praise? So this is a wonderful video of a dog that's being restrained without food. And you see so many signs of stress with this dog and so much resistance. And so I'll show you this. There's a lot of panting in that video, a lot of lip licking, a lot of kind of hyper vigilance, sort of looking around. She resists a little bit. Had this, I think, persisted without the food distraction, you'd probably get a lot more resistance. And then this is restraint with food distraction. Dr. Rodosto, once again, you see her kind of scratching the dog and petting the dog while she's doing her exam. Keeping that touch gradient, helping keep the dog's stress level down. She's massaging. And you see that continual contact all the way to the back, doing a kind of hind end, or she's doing abdominal palpation, but as she makes her way to the back, she just continues to glide all the way along there. So for injections, when we're doing injections, we want to, with any food distraction, kind of start by offering food, make sure that that's food that they're interested in. We do tend to kind of do a couple gentle pets, a little bit of pinching, and get the patient kind of accustomed to that touch and that pinch prior to giving the vaccine or the injection that you're giving, if possible. Warming up sub-Q fluids to body temperature is really pleasant for them. It does make the experience better if we can. And please change your needle after every attempt. We should never, ever be reusing needles. So if you go to inject, unfortunately the animal wiggles, you need to pull the syringe and needle out. We need to change the needle. So this is a video. This dog was trained using cooperative care training techniques, so consent training. So I taught her to go up onto that platform. She did tend to seek height because she was stressed in clinic. And so rather than kind of climbing onto a chair where it was a little bit hard to get around her, she decided that this platform would work for her. And what I do in this video is I'm just kind of petting and pinching first, and then I do the real injection the second round. The second time around, I'm giving her a vaccine. She has been trained to do this. So you hear me using predictor cues is what they're called, but this is the same rules apply regardless of whether the animal's been trained or not. You're going to pet, you're going to get them comfortable with the petting, do a little bit of pinching, and then give your injection. You don't see continuous feeding in this video because this is more of a training session. But when I give an actual injection, I tell the owners to start feeding regardless of whether we've trained it or not. So that is for injections. This is a really beautiful video of the pinch and roll while you give the vaccine that can help a lot with sensitivity to the needle. And this cat is also enjoying some canned food on a tongue depressor. You can also see we had some hot dogs to try. We've got some Temptations in the back and some toys. So when this cat first came in, she was newer, and which with a lot of our shelter patients, we don't really know them. And so we had to try a few different things. We had to see what was motivating for her. And so that's why you see all those things on the exam table. Oh, sorry. So considerations for venipuncture, which patient or which position, sorry, is your patient most comfortable? And so we really, if we can do the blood collection or the IV catheter placement in a position, they're more likely to stay in that position. There's going to be less resistance. And so there's a few things though to consider. When we have patients that are concerned with paw handling or nail trims, they may be a little less comfortable as far as cephalic venipuncture is concerned. Dogs that are standing tend to do well with a lateral saphenous blood collection, as well as if they're in sternal. So if they're sternal, they can lay with their leg out. Relaxed, those guys are often very comfortable having food distraction while you pull from one of those from a back leg. Using lidocaine cream can be beneficial. When this occurs though, we need about 30 minutes prior. So we do put it on, we have to wait 30 minutes and then you can do your venipuncture from there. It's really helpful for IVs, I find in particular, especially if you have a surgical day and everybody's in their kennels waiting for surgery. You can shave, place it on, assuming that the shaving isn't going to cause too much stress. And then by the time you're ready to place your IV, timing wise, it tends to work out. If you are shaving a spot. Clippers are loud. There are some quieter ones that you can purchase, but starting from far away and then slowly moving your clippers closer rather than placing them, especially like if you're doing a jugular collection, placing the clippers right beside their face and then going to pull blood is definitely often causes them to startle. So this is a food distraction for a blood draw. This is just a sticky little, they're called chomp and stick bones, and we got them off Amazon, and then we have some Cheese Whiz smeared on them. And then for cats, we don't need to be stretching our cats for jugular collection. They can sit calmly. We just use the V, is what I call it. And you can just put your thumbs behind their ears and then just gently lift their chin up with your forefingers. And often with any venipuncture that you're going to do, kind of stroking the area, just like we do for our vaccines and our other injections, kind of stroking the area, putting a little pressure there to get them acclimated to that, comfortable with that, prior to actually placing the needle inside the vein. Cephalic is ideal for IV catheter placement for the majority of cats. Keep in mind though that if their paws are sensitive as well. Medial saphenous I find works really well once they're remaining in sternal, and we have so many cats that will take food while in sternal and getting a blood collection. That way we don't need to be karate chopping our veins, is what I call it. We just need to be using gentle pressure. I think in tech school a while back, I remember like really like holding on for dear life, but we don't really need to be doing that to get our blood collection. This is just a really nice picture of a cat in a sternal position, getting a medial saphenous blood collection, having some head scratches. And then X-rays, radiographs. These are generally procedures that should have sedation, PVPs and or sedation. But in 90% of the patients in our practice are sedated for radiographs. And this video explains why really, really well. It's scary for them. So this is from the dog's point of view. Or cats, I suppose. Right. So that's stressful. That would definitely be stressful. It's helpful for radiographs to place a non-slip mat onto the X-ray table. Having troughs absolutely are recommended. And often if we have patients, particularly that are just maybe needing a VD, we can use treats. We often will use treats. And so this is a nice picture of a mat that's just on the X-ray table, dog's in lateral. And then this one, the dog is getting a VD and having a nice Kong with some treats in there while the X-ray is being taken. I know in Canada in particular right now, there's a lot of hands-free radiographs being done. And I think a lot of those patients probably are sedated or should be sedated because they're placed in positions with weights, essentially with the sandbags. And so that could be potentially pretty stressful as well. And so that's my take really on radiographs. Like there's not a lot of patients that are really comfortable with the sound, with the tables, with the positioning. And that's where your pre-visit pharmaceuticals and your sedation can be really helpful. So nail trims. This is my soapbox. If I get on one, this is generally where it happens. So nail trims cause so much fear, anxiety, and stress in patients. And I think it is definitely one of those things that can be made better through pre-visit pharmaceuticals, but also through food distraction. A lot of times we can get our nail trims done with food distraction in particular. I will say that the majority of dogs and cats do prefer to be standing for their nail trims, or in their owner's arms or in a staff member's arms. And so I say avoid lateral. And when I mean avoid lateral, I mean, I sometimes say, if I went into a fitness facility and I was getting a personal trainer and I walked in and they said, hey, I'm going to place you in a headstand, I would get a little bit nervous, right? I don't want to do that. I don't know what that feels like. And I feel like being placed in lateral for a lot of patients just is so stressful. They have no control or choice. And so if we can avoid it, let's avoid it. There is the odd dog and cat that when placed in lateral will still eat food, but I do not see it often enough. It is definitely one of the least used positions in our practice in particular. And then scruffing. I can do a whole presentation on scruffing as well, but it's not recommended. It's not recommended for nail trims. It's not recommended for any procedures. It does increase fear, anxiety, and stress. We know this. And so as an alternative, using towel wrap techniques can absolutely be helpful for the situations where you feel that may be required, as well as pre-visit pharmaceuticals. And I just dial back there every once in a while. And so, because if what we're doing can increase fear, anxiety, and stress, that's where we need to consider whether psychopharmacology is going to be beneficial. So this is a video of a kitty cat having his nails trimmed with food distraction. If I was being very picky about my technique, that paw is too high. We also need to consider that when we're doing nail trims, that when we do lift a paw, the animal becomes off balance, right? So we just need to consider that. So I often, now this is a pretty old video, now I make sure that I leave the paw a little bit closer to the surface so that the animal feels a little bit more stable. The higher the paw goes, the more unstable they feel. And so what do we do when distraction doesn't work? I've touched on it a few times, but we're going to stop. We need to pause, postpone, and make a new plan. So when we've paused and we've kind of taken a step back and thought, you know what, we've tried to restrain, we've tried to use food, this isn't working right now. The first thing we tend to do is increase our food value. Will this patient work for something higher value? Maybe the whipped cream isn't working and they would prefer to have some tuna. Can we change our handling technique? Is there someone in the practice that this patient is more comfortable with? Is there a volunteer that they're more comfortable with? Can we maybe place the patient in a different position? Can we change environments? And I find that this works so frequently that a lot of exams are done outside. When it's not -30 in Canada. We spend a lot, and you guys are in beautiful San Diego, well, some of you. And so it's wonderful to be able to kind of work outside if it's safe to do so. A lot of, not cats, I'm not recommending the cats are outside, but dogs in particular do like to be outside. And I find that procedures and examinations work really well, like just your wellness exams, your vaccines and that sort of thing. Communicate what you're seeing. And so this is important if there is an owner present. This is important if there isn't an owner present. This is for your team members as well. I will often, while the veterinarian is doing the physical exam or whatever they're doing, I will be saying, okay, still taking food. Yeah, ears are forward. Oh, he just stopped eating. Oh, his tail's tucked. Like that, that's literally the conversation. We're always talking back and forth about what's going on. The vet's going to tell me, okay, I'm giving the injection. Okay, I need to lift his tail. And we'll talk kind of back and forth about what's going on. The benefit, if you have an owner present to doing this, is that if you need to stop a procedure, they have heard you. They've heard you discuss the body language. And then when you have to have that conversation, and we do it because we're in a general practice all the time. So when we need to stop, we will explain, listen, Fluffy is panting, yawning, turning away. Her tail's tucked. She no longer wants to take the treats that we're providing. Do you have anything that you know that might make her more comfortable? Often at that point, the client can also become stressed as well. And so that's kind of our segue into, do we need to use medication? Do we need to reschedule this appointment or this procedure? And this is a big no, thank you. And my communication is late on it, but I think this is also another patient that we had trained for cooperative care. We realized in hindsight, this dog had never seen his veterinarian with a mask on. And I think that is partly to do with what happened. And also he did the training a little bit differently. So you're going to see some wonderful body language in here, and you're going to see a very obvious, you can stop that right now. And so you see the look away. There it is. And it was so fast. And I've known this patient for 2 years. And so, and I've worked with him for a while on and off. And so I was a bit surprised at that response. And so you see me tell him kind of late, like, oh, he lifted his lips and he growled consecutively, very, very quickly. And so the remainder of this patient's exam, because this dog is comfortable with me, the remainder of this patient's exam was done as a distance exam. So he came off of this platform on his own. He decided he did not want to be up there anymore. And he was comfortable with me lifting his tail and me lifting his paws. His owner is present, she's feeding, and that's how we did the rest of it. And so it's honestly dependent on what is needed, but that was substantial enough for this patient. So needs versus wants. Needs are necessary diagnostics. So it's immediate, it needs to be done. These are diagnostic blood work, radiographs, ultrasounds, things that are painful. Our eye infections, our ear infections are painful, right? Your torn nails are painful. Emergencies, obviously you're hit by a car, any altercations between dogs. Anything elective is a want. Okay, these are nail trims, weight checks, vaccines, microchips, preventative blood work, and anal glands to a degree. And so when we need to stop and distraction isn't working, we need to stop and think, is this a need versus a want? Can we try again later with this patient? Can we place this patient on pre-visit pharmaceuticals and try again? So when are we stopping? When are we making that decision? So Dr. Heron she showed you the FAS scale, and when you're in the 4 and 5, we're absolutely, those are our stops, those are our big red flags. But even our 3s, sometimes they start what I call angry eating, and they're grabbing treats more roughly. They're not comfortable, they're hypervigilant, they're moving around the space. With our cats, you might get some vocalizing. And we don't want to cause psychological damage long-term with these patients. And so that's when we're going to stop. We're also going to stop if we've tried gentle control, we've tried considerate approach, we've incorporated touch gradient, we've tried some different food distractions, some petting, some verbal praise, and it's just not working. These patients can be rebooked, or we can, if we're in a shelter environment, they can be rescheduled for another day, and we don't want to cause any more stress for that day for them. If we need to use equipment, and when I'm talking about equipment, I'm usually talking about muzzles. Cone collars I find also work fairly well in emergent sort of situations for these patients, but if they're not preconditioned to a muzzle and it is going to be traumatic to get the muzzle on, it's not recommended and we should consider stopping. And muzzles often can be end up as band-aids essentially, and it can cause some serious emotional damage long-term. So I do have a muzzle trick though I can share with you. So with our muzzles in our practice, we will take saran wrap and we smear Cheese Whiz on them. We don't have peanut butter just for allergic reasons. And then I put it on the mouthpiece of the muzzle, and you can either just use that to get the muzzle on, and the dog can be licking the Cheese Whiz, remove the plastic once it's on there, can be licking the Cheese Whiz while you're getting the muzzle on, but also you can freeze those. So we have a few that are frozen as well, so it lasts a little bit longer. And if we're literally putting a muzzle on for an IM injection for sedation, it can all be done very, very quickly. And then the drive-by sedation works beautifully as well. But if we are going to cause more harm than good using equipment, and we can be using pre-visit pharmaceuticals and or sedation, then that's the route definitely to take. So for teamwork, it's always teamwork, right? We need to have a plan. We need to be talking to one another about what's going on with the patient. We need to be reading body language and assessing every single time. We're using gentle control and considerate approach, touch gradient. This has to all happen simultaneously. Sometimes it feels like, but the communication between the team members, between reading the patient, is going to make things much more fear-free. And then having our environment set up for success, right? Being able to block out a lot of noise, being able to block out visual stressors, being able to have all our equipment ready for our procedure. All of these things matter to our patients when we're setting up a fear-free environment. So if you are interested and you want to learn more, Fear Free has a wonderful shelters course. There's fearfree.com where you're going to be looking at your different certifications. They have a grooming one now, trainer, veterinary professional, equine, avian, and then Fear Free Happy Homes has wonderful client handouts, and it's free. It's free membership. And if you're looking more into cooperative care, kind of veterinary visits, and want to learn more about that, that's a wonderful course, Better Veterinary Visits, through the Karen Pryor Academy. I love the From Fearful to Fear Free book, and then Cooperative Veterinary Care is my Bible. And then you have Dr. Sophie, and of course, Low Stress Handling and Restraint book that has really good towel wrap techniques in it. And so if you're looking to learn more, these are those resources to do so. If you have questions for me, you can email me at jessica@companionvet.ca. Our website has a resources for dogs and cats page as well. So I do have a lot of like house training, crate training, teaching your pet to enjoy being handled, which can be really beneficial, and then puppy webinar and that sort of stuff. And then we have a training page, which is the ones on here, because I, as a veterinary technician with a specialty in behavior, I do a lot of training. And so rather than me taking over the whole veterinary clinic pages, that's those are my pages. So I don't take over everything in our practice. So that's it for me. If you have questions, I'm happy to answer them. Yeah, thank you for having me and thank you for watching.
If anyone has questions, you can pop them in the chat or in the Q&A. And I know we did go a little bit over, so if you have a question and you want to stay and ask, you're welcome to for the next couple minutes. If you do need to go, you are welcome to do that as well. I will be sending out the presentation recordings and also the notes for both presentations this evening. Any questions for Jessica?
No, we're good.
All right, well, thank you all so much for attending today. Thank you so much to our speakers for all the wonderful information you shared. We're so grateful to have you this evening, and we are so honored to be able to partner with Fear Free for this presentation. Hope everyone has a wonderful evening.
Thank you. Have a good night.